Welcome to the deep dive. Today, we're really getting into something quite specific but fascinating: hyperbaric oxygen therapy, HBO, and how it's being looked at in neurosurgery.
That's right. We've gone through a lot of the medical literature trying to pull out the key insights for you.
Yeah, we're covering a pretty wide scope, things like traumatic brain injury, TBI, spinal cord injury, vascular problems in the brain, even tumors and infections.
Exactly. And the goal here is to give you a solid understanding, sort of the current state of play, without you feeling like you're drowning in medical jargon. We'll hit the crucial points, maybe some surprising findings too.
Right. So our sources are mainly medical studies, focused specifically on these neurosurgical applications. And our mission, I guess, is to understand where HBO therapy stands right now in this field, the mechanisms, the uses, and what research is still ongoing.
Let's jump in.
Okay, so traumatic brain injury, TBI. This isn't exactly a brand new idea for TBI, is it? Using oxygen.
No, not at all. Actually, reports suggesting HBO could help with cerebral edema, that's, the brain swelling, they go back more than 40 years.
Ah, okay.
Yeah. And more recently, we've seen studies that seem to confirm those early ideas. For a while, there was maybe some uncertainty because the mechanisms weren't perfectly nailed down, but that picture is becoming clearer.
So fundamentally, why would pumping more oxygen into the system help a brain that's just been injured? What's the basic rationale?
Well, the core idea is pretty straightforward. HBO dramatically increases the oxygen dissolved in your blood plasma. After a TBI, the brain often suffers from hypoxia, not enough oxygen, but sometimes also hyperoxemia, which is actually too much blood flow in certain areas. Both are bad.
Right. Problems on both ends.
Yeah, exactly. And HBO aims to kind of normalize that oxygen supply and potentially blood flow dynamics.
You mentioned a cascade of events after TBI in the outline. Can you sort of paint a picture of that? What happens and how does HBO try to, well, interfere?
Sure. So after the initial hit, you can get this damaging sequence. Things like ischemia, restricted blood supply, the edema or swelling we mentioned, then increased intracranial pressure, ICP.
That's the pressure inside the skull.
Exactly, which is obviously really dangerous if it gets too high. Plus, you get physical disruption to cells and all sorts of metabolic and enzymatic problems kicking off. HBO seems to work on a few levels to try and break that cycle.
Okay, like what specifically?
Well, one really important mechanism is vasoconstriction. The high oxygen levels actually cause blood vessels to narrow slightly.
Okay.
And that sounds maybe counterintuitive, but it helps reduce the overall cerebral blood flow, which in turn can lower that dangerous intracranial pressure, the ICP.
Huh. Interesting.
Yeah, and what's also interesting is studies suggest it might help stabilize the blood flow within the damaged tissue itself, minimizing those kind of wild swings you can get after an injury.
So, wait, more oxygen makes blood vessels constrict, reducing overall flow? But somehow it might help flow in the injured part? How does that work?
It does sound like a paradox, doesn't it? But the thinking is, by reducing the edema, the swelling, HBO might actually improve the microcirculation in those compromised areas, even with the general vasoconstriction happening elsewhere. It's complex how the brain responds.
Definitely sounds it. So what about the immediate effect on ICP in those critical first hours or days after a TBI?
Yes, studies have shown HBO can bring down ICP, and interestingly, even just giving 100% oxygen at normal pressure, that's called normal baric hyperoxia, that alone seems to have some positive effects on brain oxygen metabolism and ICP. And after an HBO session, you often see the ICP continue to decrease for a period.
So does that mean maybe just high flow oxygen, not necessarily the pressure chamber, could be enough sometimes?
It's a really good question. And, the evidence suggests normal baric oxygen could be a very reasonable first step or maybe part of the treatment. But using HBO effectively really requires careful monitoring.
Monitoring what?
You need to watch the patient's neurological status constantly. Their ICP, of course, and often measures of cerebral metabolism. Things like the lactate to pyruvate ratio, brain tissue pH to figure out the best pressure, the best duration, the frequency of treatments.
And you mentioned avoiding oxygen toxicity. That sounds like a real concern with giving high concentrations under pressure.
It is a potential risk, yeah.
Yeah.
But it's very much dose dependent. That's why the dosimetry, controlling the pressure and the time very carefully, is so critical.
Right.
Plus, the vigilant monitoring helps. HBO is usually given in sessions, intermittently, allowing the body's own antioxidant systems time to recover between treatments. And generally, for these CNS conditions, the pressures used are around 1.5 to 2 atmospheres absolute, or ATA. That's generally considered a safe range.
Okay.
Sometimes treatment protocols might even alternate HBO sessions with periods of just normal baric oxygen.
Got it. So that covers the acute phase pretty well. But what about longer-term problems after TBI? We hear a lot about post-concussion syndrome, PCS these days.
Absolutely.
Yeah.
There's much more attention being paid now to the chronic effects. PCS is a big one, and there seems to be a potential link, especially in veterans with blast-related mild TBI, between PCS and PTSD.
Hmm.
We have imaging techniques now, like DTI, diffusion tensor imaging.
That looks at the white matter, the brain's wiring.
Exactly.
Yeah.
And studies using DTI have shown white matter injury even in mild TBI, especially if there was loss of consciousness. And importantly, the extent of that injury seems to correlate with how severe the PTSD symptoms are and with neurocognitive problems.
So could HBO help with these chronic issues potentially years later?
Well, there was a phase I studied, quite notable, involving veterans with chronic blast-induced mild TBI and PCS. They received 40 HBO sessions at 1.5 ATA.
40 sessions, that's quite a commitment.
It is. And the results were significant. Improvements were seen across the board in symptoms reported by the vets themselves, physical exams, cognitive tests, quality of life measures, and even on SPECT scans, which look at brain blood flow.
Wow, that's promising.
It is. And of course, we're also learning more about chronic traumatic encephalopathy, CTE, from repeated head hits, like in sports. That's another area of concern.
It feels like there's quite a bit of research history here. You mentioned Table 21.1 in our source docs, summarizing some older studies.
Yes, some foundational work. People like Coe and Hayes back in the day showed HBO actually increased lifespan in rats with experimental brain injuries.
Yeah.
Sukoff and others demonstrated it helped with cerebral edema. Holbach found better results in acute injuries, looking at ICP and metabolism.
And that Barrett study from '98 you mentioned, 120 treatments.
Right, Barrett et al., 1998. 5 patients with chronic TDI. A really intensive course, 120 sessions at sort of 1.5 ATA. They tracked things like blood flow with SPECT, speech, cognitive function.
And what did they find after all that?
They reported lasting increases in cerebral blood flow, particularly in the penumbra, the area surrounding the main injury, and improvements in things like speech fluency, memory, attention. Interestingly, the benefits seem to peak around the 80-session mark in that study.
Still, that's a lot of treatment.
It really is.
Yeah.
Other studies have pointed towards improved brain metabolism too, increased oxygen consumption, decreased lactate in the cerebrospinal fluid. And animal work, like Hart's study in 2007, showed HBO could actually increase the density of blood vessels in the hippocampus key for memory and improve cognition in rats with chronic TBI.
Yeah.
There's actually an ongoing trial looking specifically at HBO for cognitive function and blood flow in TBI patients right now.
What about the bigger controlled trials, the ones that compare HBO against, say, a placebo or standard care, Table 21.2?
Right. Those are crucial. The results there have been, well, a bit more mixed, honestly. Lin et al. in 2008 found improvements in GCS scores and better long-term outcomes on the Glasgow Outcome Scale for certain patients. Roxwold in 2010 showed HBO had a stronger effect on brain metabolism than normobaric oxygen alone.
Okay, so some positives.
Definitely. And Bussy-Gross in 2013 published really interesting findings suggesting HBO could induce neuroplasticity, the brain's ability to reorganize, leading to better function and quality of life in chronic mild TBI-PCS patients, even years after injury.
But you said mixed.
Yeah. For instance, a study by Sifu in 2014 didn't find HBO helped with specific post-concussive eye movement problems in veterans, Wolf et al. In 2015, didn't see a significant overall cognitive benefit compared to a sham treatment, although they noted some subgroups might have responded better. And there was a large phase 3 trial comparing HBO to standard beds for MTBI PCS that finished a while back, but the results haven't been published as far as we know.
So it's not quite a slam dunk from the controlled trials yet?
Sure.
Given that, how is HBO actually being used or considered in clinical practice for TBI right now?
Well, based on the available information, the approach seems to be quite considered. It usually involves a neurosurgeon, ideally starting treatment within 12 hours post-injury, assuming the patient isn't rapidly deteriorating.
Okay.
An ICP monitor is pretty much essential. Other ICP-lowering methods might be used at the same time, like hyperventilation initially, maybe even considering a barbiturate coma in severe cases.
And the HBO team?
Needs to be experienced with neurological patients. The treatment itself is typically intermittent, usually at 1.5 to 2 ATA. The frequency and number of sessions really depend on the individual patient's response, clinical status, ICP readings, brain metabolism markers, imaging, blood flow assessments.
So very tailored.
Very much so. Monitoring is Key jugular venous blood for glucose, pH, lactate, frequent neuro exams, keeping cerebral perfusion pressure adequate, usually above 70 mmHg, making sure anticonvulsant levels are right. It's a whole package.
Right.
So while it might not be fully established standard care for severe TBI across the board yet, the feeling is that more well-designed, randomized trials could really pinpoint the subgroups who benefit most and the optimal way to deliver the therapy.
Okay, that gives us a good sense of the TBI landscape. Let's switch tracks now to spinal cord injury, SCI. Is the thinking similar there? Reducing swelling and ischemia?
Yes, exactly. The core concepts are very parallel. Traumatic spinal cord injuries, or myelopathies, are often characterized by that damaging duo. Ischemia, the lack of blood flow and oxygen, and edema, the swelling. This comes from both direct physical injury and problems with blood vessel control, leading to poor microcirculation, especially in the gray matter, often with some surrounding hyperemia, that excess blood flow.
And how does the injury typically unfold in the spinal cord?
It often starts with ischemia in the gray matter. Then you might see an increase in overall spinal cord blood flow for a time, followed by the development of edema, particularly in the white matter tracts.
And the evidence for HBO and SCI, you mentioned it's maybe less consistent than for TBI?
Generally, yes. There have been clinical studies suggesting benefits, but maybe not as strongly substantiated overall. The major exception seems to be when treatment is started very early.
How early are we talking?
The sources really emphasize a window of about 2 to 4 hours post-injury.
Wow, that is incredibly fast.
It really is.
Yeah.
The idea is that this might be the critical period before irreversible anatomical damage sets in. If the cord is physiologically stunned, but not yet permanently disrupted, HBO might have its best chance.
So within that narrow window, what indicates someone might respond?
Patients who don't have definitive anatomical disruption seen on imaging MRI, CT, X-rays, and who receive HBO within those first few hours, they may respond. Close monitoring is vital, using things like SFPs, those somatosensory evoked potentials, to track nerve function.
Right.
And if you see clinical improvement or improvement on the SAP tests, then continuing HBO is generally indicated. And of course, maintaining spinal alignment, especially with neck injuries, is absolutely paramount. You even need special traction setups compatible with the hyperbaric chamber.
What's the specific rationale? Why might HBO help in those initial hours for SCI?
The hope is that if the damage is more like a severe bruise than a complete severing, HBO can help rescue neurons. It aims to relieve that gray matter ischemia, reduce the white matter edema, and maybe correct some of the biochemical problems like lactic acidosis that build up locally.
The ally mentions quite a few animal studies on SCI too. What did they find?
Yeah, the animal work has often been quite encouraging. Studies going way back, like Meta in '65, showed HBO boosted oxygen levels in injured dog spinal cords. Hartzog in '69 reversed deficits in baboons. Kelly's work in the '70s showed HBO improved recovery in paraplegic dogs, similar to steroids or hypothermia.
So consistent positive signals in animals?
Pretty much. Yao's studies in sheep showed better motor recovery and less tissue damage with early HBO compared to controls or even steroids. Higgins suggested early HBO might protect against ongoing destructive processes after impact injuries in cats. Sukov's work in cats and gerbils showed prevention of paralysis and better walking recovery with immediate HBO. And more recently, Carmen found HBO reduced oxidative stress markers in rats, something methylprednisolone didn't do in their study.
That's a lot of supportive animal data. How does that translate to human studies? You said they were more limited.
They are fewer and sometimes less clear-cut, often because of the timing issue. Jones, in '78, saw some functional recovery in patients treated within 12 hours, with some complete injuries becoming incomplete. Gamache, in '81, noted faster recovery rates if HBO started around 7.5 hours post-injury, getting patients closer to their expected one-year outcome much earlier, but they stressed that ideally you'd want to start within 4 hours.
Right, that 4-hour window again.
Exactly. Sukov used a whole protocol, including early HBO, and reported motor improvements if treatment began within 6 hours. Yeo reviewed cases from the late '70s, early '80s, and found better recovery in certain types of lesions with HBO, though the average delay was 9 hours. And crucially, all the patients who recovered had incomplete injuries to begin with.
Timing is just everything here, isn't it?
It really seems to be the critical factor for SCI. And hitting that 4-hour target in a real-world trauma situation, well, it's often very difficult logistically.
Yeah, I can imagine.
Which has led to ideas about maybe needing mobile hyperbaric units, or even considering prophylactic HBO for all SCI patients with any neurological signs in those first few hours, just to try and head off the edema and secondary damage.
What about later on? Does HBO have any role in SCI rehabilitation?
There's some suggestion it might. Lower pressure HBO, like 1.5 ATA, might improve exercise capacity and reduce fatigue-related metabolic issues. Studies in quadriplegics found HBO didn't harm lung function and might have even improved vital capacity slightly. And there are anecdotal reports and some evidence that it could help reduce spasticity, especially combined with physical therapy.
Okay. The materials also mention compressive and ischemic spinal cord lesions, not just trauma. Does HBO fit in there?
Yes, there's some evidence there too. Holback reported improvements in patients with things like cervical disc compression or cysts after they had surgery in HBO. They saw better oxygen levels in the spinal fluid, better muscle activity on EMG. Ishihara even used HBO response to try and predict surgical outcomes in cervical myelopathy.
Interesting, like a diagnostic tool almost.
Potentially, yeah, showing if there's reversible dysfunction. And Ravikovic reported good results using HBO alongside surgery and antibiotics for spinal epidural abscesses. Narraton found HBO helped with neurological deficits in certain types of spinal circulatory problems more than vasodilator drugs did. So overall, it seems beneficial for some patients by tackling that ischemia component.
Okay, let's pivot completely now. Brain tumors. How does HBO potentially fit with radiotherapy?
This is a different angle entirely. The main idea is to overcome hypoxia within the tumor.
Hypoxia meaning low oxygen.
Right. Many tumors, especially aggressive ones like glioblastoma, have areas with very poor oxygen supply. And those hypoxic cells are notoriously resistant to radiation therapy.
Ah, so the radiation doesn't kill them as effectively.
Exactly. The theory is that flooding the tumor with oxygen using HBO right before or during radiotherapy could make those resistant cells more sensitive, boosting the treatment's effectiveness.
And the studies.
Chang's trial back in '77 showed a trend towards better survival in glioblastoma patients who got HBO with radiation. But it wasn't statistically significant, likely due to small numbers. Koshi's pilot study in '96 was promising, showing more tumor shrinkage in malignant glioma patients who got HBO right after radiation compared to radiation alone. They've continued research suggesting timing is key radiation given within about 15 minutes of the HBO session seems best.
Intriguing. What about neuroprotection during surgery itself? Zeong's study.
Yeah, that was experimental work suggesting preconditioning with HBO might protect the brain somewhat, potentially limiting injury during invasive procedures where you might anticipate some temporary lack of blood flow.
Okay. Now, another area that seems surprising, CNS infections. How is HBO used there?
This is actually a really interesting and growing application, particularly for postoperative infections after neurosurgery, like craniotomies or spinal surgeries.
Infections after surgery can be devastating.
Absolutely. And several studies, like Larson's reviews, have shown really good results using HBO as an adjunct treatment. They found high rates of successful healing, often without having to remove implanted hardware or bone flaps, which is a huge advantage.
Even in kids.
Yes, Larson looked at complex pediatric scoliosis cases too, with good outcomes. And In and Maz's study actually look at using HBO prophylactically, giving it before potential problems arise in high-risk scoliosis surgery, and found it significantly reduced the infection rate compared to standard antibiotic prophylaxis alone.
Wow, so preventing infections too.
Potentially, yes. And Pareson's study showed HBO was effective as an add-on therapy for spinal infections that weren't responding to medical treatment, helping to avoid revision surgeries or implant failure.
That's quite compelling for post-op situations. What about brain abscesses? Those are notoriously difficult too.
Very difficult, often caused by anaerobic bacteria, which thrive in low oxygen environments. Antibiotics alone might not be enough, and surgery carries risks.
So HBO seems like a natural fit.
Exactly. The rationale is multi-pronged. HBO is directly toxic to many anaerobic bacteria. It could work synergistically with certain antibiotics. There's some thought it might temporarily open the blood-brain barrier, helping antibiotics get in better, and it definitely helps reduce the surrounding brain edema and ICP associated with the abscess.
Any clinical evidence?
Yes. Lampel back in '89 reported excellent recovery in patients treated with adjuvant HBO. Kersel found it safe and effective in children, potentially shortening IV antibiotic courses and hospital stays. Animal studies support using it early, and case reports show it helping in really tough situations, like abscesses resistant to antibiotics or in difficult locations. A larger cohort study by Bartek recently suggested adjuvant HBO was linked to fewer reoperations, fewer recurrences, and better overall outcomes for spontaneous brain abscesses.
So definitely a strong contender as an adjunctive therapy for CNS infections.
It certainly seems so, addressing multiple facets of the problem.
Okay, last major area, cerebrovascular surgery. Strokes, aneurysms, bypasses. Where does HBO come in?
Well, for acute stroke primary cerebral ischemia, its effectiveness is still debated, as we mentioned, but is being explored more as an adjunct in various surgical contexts.
Such as.
Things like providing extra brain protection if surgeons need to temporarily clamp off a blood vessel during a procedure, like a carotid endarterectomy cleaning out neck arteries, or using it preoperatively in high-risk carotid patients. Also, managing complications after surgery for intracranial aneurysms, like vasospasm or swelling.
Vasospasm is a major risk after aneurysm rupture, isn't it?
It is a dangerous narrowing of blood vessels, and HBO has been looked at to help manage that. It's even been proposed as part of the decision-making process for surgeries like carotid endarterectomy or the ECIC bypass.
Ah, yes, the ECIC bypass, extracranial intracranial bypass. That had a complicated history.
It did. The big cooperative study in 1985 famously concluded it wasn't better than medical management for preventing strokes, which really curtailed its use for a long time.
But the sources here suggest HBO might refine who gets that surgery.
Exactly. The limitation of that big study was that it didn't look at patient subgroups. Holback and others proposed that if a patient with chronic stroke symptoms showed neurological improvement during an HBO section,
It meant there was still viable brain tissue, idling neurons.
precisely, tissue that was alive but not functioning due to poor blood flow. The idea was these HBO responders might be the ones who would actually benefit from restoring blood flow with a bypass. Several other groups followed this line of thinking, using EEG changes during HBO, along with the clinical response to select candidates.
So HBO as a selection tool?
Essentially, yes. If someone didn't respond to HBO, the argument went they were less likely to benefit from the bypass surgery anyway. It helps identify that potentially salvageable penumbra. There was even talk about whether long-term HBO itself might be an alternative to bypass in some of these responders.
That's a fascinating twist on the ECIC story.
Yeah.
What about after aneurysm surgery, helping with complications?
Yes, several surgeons reported good results using HBO to prevent or treat neurological problems arising after aneurysm repair, often related to that vasospasm or edema. Kitokoka used it for post-op mental status changes linked to anterior cerebral artery spasm. Isakov found it led to quicker recovery, fewer complications, and better outcomes overall. Koshi found it useful alongside other treatments for mild vasospasm.
So it seems to pop up in various niches within cerebrovascular work.
It does, both for potential direct neural protection and as this interesting tool for assessing tissue viability and guiding treatment choices. There's also mention of using it preoperatively for intracerebral hematomas to help decide on surgery, or preconditioning before surgeries where ischemia is anticipated.
We have covered a huge amount of information today: TBI, SCI, tumors, infections, vascular issues. If you had to distill it down, what are the main takeaways about HBO in neurosurgery right now?
Okay, well, I think firstly, the strongest case is probably for acute TBI. There's pretty solid evidence it helps reduce edema and ICP. It's increasingly seen as part of a comprehensive management strategy to improve outcomes. And there's growing interest in its role for chronic issues like PCS-PTSD too.
And careful dosing and monitoring are key there.
Absolutely. Starting around 1.5 ATA seems common, and its use for post-op edema is also fairly well accepted. For acute SCI, treatment is still challenging, but HBO shows definite experimental promise and some clinical hope if, and it's a big if, it can be given extremely early.
Right, that critical window.
Yeah. Then you have its role in helping make decisions, like with intracerebral hematomas, or potentially redefining indications for things like ECIC bypass based on patient response. And its use as an adjunct for CNS infections, especially post-op and abscesses, looks really quite promising.
So summing up, TBI seems to have the most momentum towards wider acceptance.
I think that's fair to say, yes. The evidence base there is arguably the most developed and closest to potentially becoming standard practice in certain situations.
All right, so a final thought then for you to consider. Given all these potential benefits across such diverse neurological conditions and all the ongoing research, how do you see HBO therapy continuing to evolve within neurosurgery? What breakthroughs might we see next that could further sharpen its use for these complex CNS problems? It's certainly a field to watch. Thanks for joining us for this deep dive.